Good evening, everyone. I hope you are all able to enjoy this beautiful day today. My name is Julie Brooks, and I am co-chair ambassador of the James Ambassador Society. I appreciate you tuning in tonight and to hear from the division that is committed to research, education, and outstanding outpatient and inpatient clinical care for patients with non-malignant and malignant blood disorders. We have over 60 guests joining us this evening, and I thank all of you for your commitment to learning more and advocating about the work happening at the James Cancer Hospital and Soloff Research Institute. If you have any questions throughout the session, please use your Q&A feature at the bottom of the screen. At the conclusion of the discussion, we will answer those questions if time permits. I'd like to welcome Director of the Division of Hematology at Ohio State and holder of the J. Coughlin Chair in Cancer Research, Dr. Yiping Yang. Welcome, Dr. Yang.
Thank you, Julia. First of all, I would like to thank Jamie and the James Ambassador Society for organizing this event. Good evening and welcome to the OACU Hematology. I'm Dr. Yiping Yang, Director of Division Hematology at the OACU Comprehensive Cancer Center and the James Cancer Hospital Soloff Research Institute. I joined OACU from Duke University in August 2019 to lead the Hematology Division. I'm a physician scientist. My clinical expertise is in lymphoma and leukemia. And as a scientist, I have a long-standing research interest in cancer immunotherapy. I must say it has been a great and exciting experience here at OACU and the James, and I've enjoyed every minute of it. This is a great place. We have a top cancer center, the James with high patient volumes, an outstanding group of nurses, pharmacists, social workers, and other supporting staff, great institutional commitment and support from the James, the Cancer Center, the Wexner Medical Center, a highly collaborative research environment, and a great partnership across the university. And importantly, a great supportive community, grateful patients and families, community partners. Here, I would like to take a moment to thank you for your support. Next, I would like to give you a brief overview of our division, as well as our mission and the specific goals. Division of Hematology is a multidisciplinary basic, translational, and clinical research and clinical care program whose overall goal is to improve outcomes of patients with hematological diseases. It's a big division with 71 faculty members, 6 disease groups, including acute leukemia, chronic leukemia, benign hematology, lymphoma, bone marrow transplant and cell therapy, and myeloma. It is also a very balanced division in terms of our faculty composition. A quarter of us are PhD scientists focusing on basic translational research and bench discoveries. And another quarter are physician scientists focusing on bench discoveries and patient care. And about half of us are clinicians and clinical investigators focusing on clinical research and patient care. Within each disease group, we have physicians and scientists work closely on a daily basis to lead scientific discoveries, to translate new ideas into novel therapies to benefit our patients, as well as to provide outstanding care for our patients. Last year, we conducted about 318 clinical trials, published about 180 original research papers, with many of them in top journals, and also enjoyed $30 million research funding from NIH, private foundations, and the industry to support our basic translational and clinical research. I'm honored to lead the division and grateful to be surrounded by a group of outstanding leaders. Dr. Benson is our Deputy Division Director who also leads the myeloma program. Dr. Leblanc-Balla oversees divisional basic translational research effort. Dr. Wyatt leads division-wide clinical research as well as our chronic leukemia program. Dr. Walker oversees our inpatient operations and leads the acute leukemia program. Dr. Jagrowski leads our outpatient operations. Dr. Bialki is in charge of divisional mentorship and the faculty development program. Dr. De Lima is in charge of our bone marrow transplant and cell therapy program. Dr. Maddox leads our lymphoma program. Dr. Catalan leads the benign hematology program. Dr. Rasco oversees our oncogeriatric program. Dr. Desai leads our sickle cell program. Dr. Masami oversees divisional academic affairs, and Mr. West is our division administrator. This leadership team is a key component not only of our demonstrated success, but our potential for future growth and achievement. Thank you, team, for your dedication and outstanding leadership. Next slide, please. So our mission is to build top interdisciplinary basic, translational, and clinical research programs and the collaborations, and to improve access to and deliver high-quality care for patients with blood cancer and other life-threatening hematological diseases. And finally, to educate and train next generation of academic hematologists. The ultimate goal of the three-pronged mission of excellence is impactful research, high-quality patient care, and engaged education is to improve the quality of life for all patients. Next slide, please. With this in mind, our specific goals are to strengthen basic translational research and discoveries to generate novel ideas and strategies, which then are used to support and growth our investigator-initiated clinical trials, leading to the development of new therapies such as targeted therapy, immunotherapy, cell therapy for the delivery of cutting-edge, high-quality patient care. To explain why these novel therapies are necessary and how they come to fruition, please enjoy the following video.
CLL, or chronic lymphocytic leukemia, is the most prevalent leukemia in adults. It's primarily a disease that we see as people age, though lots of young patients are diagnosed with it too. And it's generally considered a disease that people can live with for a long period of time, but it's really heterogeneous. So some people will be diagnosed in their 70s or 80s and may not even need treatment for the disease. Other people, especially those that are diagnosed a little bit younger, will have more aggressive disease and disease that comes back despite multiple therapies. My laboratory focuses on finding new therapies for patients with CLL and finding reasons why therapies don't work well and what we can do for that. So I have research scientists, postdoctoral fellows, technicians, graduate students, and we all work together for that common goal. One of the biggest advances we've made in CLL over the past 10 years is the development of novel therapies. So prior to that, all patients with CLL were treated with chemotherapy drugs, which worked fairly well but had a lot of toxicities with them, or with antibodies. The biggest paradigm shift we've had in CLL has been the introduction of therapies that target Bruton's tyrosine kinase, or BTK. And it's a molecule that's really important to keep the cancer cells alive. And by blocking that protein with a drug, we're able to really turn off the signaling inside the cancer cell. And that results in very deep and long-standing remissions for the patient. One of the reasons why we've been able to do so much good work in CLL is because of philanthropy dollars and because of patients who are willing to donate their time and a few tubes of blood to us to do research. We get some money through organizations like Pelotonia and other funding mechanisms, but a lot of our really early stage research comes from donors who are interested in the research that we're doing, so we can really bring things to the patients much faster. It's actually hard to think about just one patient who's benefited from the work that we've done, because I think the big discoveries that we've made in CLL, we've seen so many patients who did not have other options for therapies. And when we were able to introduce these very effective therapies, all of a sudden people were getting remission durations of a year or longer. And I only say or longer because most of the patients are still in remission and we just haven't had the trials open long enough.
Dr. Wyack and this video accurately displayed how beneficial novel therapies are and continue to be for patients and their families. Before we move on to the panel discussion, where we will hear from one of our experts in each disease group, I would like to welcome Professor of Medicine, Deputy Division Director, and the Director for the Myeloma Program, Dr. Don Benson.
Great, thank you, Yiping, and good evening, everyone. My name's Don Benson, and like Yiping said, I'm the Deputy Division Director for Hematology here, and I lead the program in multiple myeloma. We're going to have a chance later on to discuss the individual sections, but mainly just wanted to take a minute to say thank you to the team that put this together and for everybody joining tonight to be with us. I have the privilege of introducing our newest member in the Division of Hematology, Dr. Marcos de Lima, who came just over a month ago to assume the leadership and director position for our blood and marrow transplant program and cell therapy program. Dr. de Lima.
Thank you, Don. Thank you all for joining us tonight. I guess I'm the newest acquisition. I've been here in Columbus now for about 6 weeks, coming from Cleveland, before that from Houston, before that from Brazil. So my task is actually the easiest one, I think, is to join a group that's already doing so outstandingly well. So I think it's very nice to start up here, right? So you can potentially take that group to those proverbial next levels, but I think we are outstanding group of people. That's why I'm here. I think the institution is simply outstanding, as you folks know better than I do. And the way I look at what I do and what we do, I think the core programmatic in bone marrow transplant is going to continue to grow, although slower, while the component of cellular therapies, which is a broader sort of catchy word to say that we can genetically or otherwise manipulate different components of the immune system, this is where I envision the growth to be the next few years, both clinically and especially scientifically. So I think at the end, these two arms, right, the clinical and the preclinical, join together. So anyways, I'm very happy to be here. Thank you very much. And I'll be happy to answer questions later on.
Great, thank you, Marcos. So we'll move on into the next section and bring everybody up on the video here. And I'd like to turn things over to my colleague, Dr. Wyack.
Evening, everybody. My name is Jennifer Wyack. I'm section head of the CLL and hairy cell leukemia group and associate division director for clinical research in this division of hematology. I also serve as co-director of the leukemia research program within the OSU Comprehensive Cancer Center. I'm really excited that we have a panel tonight of excellent faculty to speak with you and then answer some questions from the audience. Drs. Benson and DeLima already introduced themselves, so I'd like to start our discussion by asking our remaining faculty to introduce themselves and explain their roles within the division. So I'd like to start with Dr. Baiocchi.
Hello, everyone. Thanks for being here tonight. My name is Rob Baiocchi. I am a physician scientist in our division of hematology, the associate division director for mentorship and faculty development, and help lead our lymphoma disease group in our division. I take care of patients with lymphoma and have a laboratory at the James Cancer Center focused on discovery of new targets that drive lymphoma growth and survival, and development of new targeted therapies and strategies to harness the immune system to treat and prevent lymphoma.
Thank you. Dr. Benson, you said just a little bit about yourself before. Can you introduce yourself and your role as well?
Sure, thank you. So in my role as the program director for our myeloma group, I have the privilege of running a research lab here with a group particularly interested in the development of immune treatments for myeloma. We focus specifically on the interface between how the immune system can detect and recognize and kill myeloma cells, and very translationally focused. We do some what they call basic science, but the vast majority of our work is really driving questions about how can we get new treatments across the street into clinical trials, and vice versa. Data and experiences we have in the clinic, how can we understand those in the laboratory? So in the myeloma group, we have 8 physicians now who take care of people with myeloma here. We had north of 6,600 patient visits. We're a very busy myeloma group. We run at any given time over 24 active therapeutic clinical trials. And importantly, we have a big commitment to education and mentorship, not only for medical students and fellows, but even undergraduate students here at Ohio State who are getting involved and want to be part of the solution with us.
Thank you. Dr. LaFalempella, can you tell us a little bit about your role within the division?
Yeah, thank you, Dr. Wyack, and good evening, everyone. Thank you for having me tonight. I am an associate professor in the division. My lab focuses on basic research in leukemia and lymphoma. In the division, I also serve as the associate director for basic and translational research. And then at OSU level, I'm also the director of the fellowship program at the Pelotonia Fellowship Program that oversee undergrad, graduate, and postdoctoral fellows.
Thank you. Going back to Dr. Baiocchi, can you talk to us a little bit about some of the novel therapies that your group has been working on?
Sure. So our lab has focused on several strategies over the years to selectively target cancer and not damage the immune system. Well, we've worked to bring several exciting strategies forward for the treatment and prevention of cancer, new drugs to directly treat cancer, and drugs to vaccinate individuals and prevent cancer. I'll just talk about one that really started as a project many years ago when I joined the division as a junior faculty member. We discovered a new target that is called PRMT5. This target, we were the first to show that it acted as a driver of cancer cell growth and survival initially in lymphoma, but then we also showed that it was relevant in driving cancers like lung cancer, brain cancer, glioblastomas, and found that this target was really not all that relevant in normal tissues. It was really only relevant in cancer. So it was in our mind, an ideal target to go after for a new therapy. And we developed the first-in-class drug to selectively target this enzyme and showed that it reprogrammed cancer cells. It didn't just act like chemotherapy, which is a non-selective method of killing cancer, like a bazooka. This is a targeted agent that actually gets into the nucleus, into the DNA, and really works to reprogram that cancer cell so it becomes more vulnerable to death from the immune system, and also just like a programmed cell death. So this was exciting to us. We went on to show that it selectively targeted malignant cells while leaving immune cells untouched, which for us was really exciting for a new anti-cancer drug. And we've come to learn that this drug looks to be very useful in treating cancers that have developed drug resistance to chemotherapy and other targeted agents like ibrutinib and other agents that are being used in the clinic. So the next step for this drug was to then try to move it into clinical development. We collaborated with probably 10 different groups here at OSU and across the country to bring it scientifically forward. Now we needed to get it into patients. So we actually, through the Leukemia Lymphoma Society and our Drug Development Institute here in the Cancer Center, were able to license our drug discovery portfolio in partnership with a pharmaceutical company to bring this novel drug forward for clinical development. A little over a year ago, after this company, Prelude Therapeutics, developed a much improved class of drug that can be systemically delivered and also get to the brain. We opened 2 clinical trials to treat patients with solid and blood cancers as well as brain cancers like gliomas. To date, we've seen several responses, including complete responses in a patient with heavily treated glioblastoma and a patient with metastatic ovarian cancer, which I should note in phase 1 trials, which really are meant to just see if a drug is safe. You rarely see these complete responses, which means complete resolution of the malignancy. So it's been real exciting and rewarding to see a project start in the lab as a discovery, as a basic science discovery, and make that leap from the lab into the clinic to help patients with cancer. I should also note that at many stages during the development of this drug and the translation into the clinic, that philanthropic dollars were key. We had support from the NIH, we had support from our Drug Development Institute, from Pelotonia, but also individuals who stepped forward, willing to take a chance and help a small laboratory really move an exciting drug forward. And for that, I am incredibly grateful and really excited about the potential of how our cancer center can partner with the community. So.
Thank you, Dr. Baiocchi, for sharing that really exciting story. Dr. Benson, I know you've been working also on some really exciting projects in myeloma. Can you tell us a little bit about those?
Sure. So I want to echo some of the comments that Rob made and some of the points that were raised in the video as well, that the role of philanthropic dollars cannot be overestimated in our work. And I think that that there's a perception perhaps that that science moves in this methodical way, that there's progress that's made step by step, and you can go back to President Nixon declaring war on cancer, and even, I think last week President Biden was talking about ending cancer as we know it, and it's true, we depend heavily on the National Institutes of Health and the NCI for funding. But the point I want to make is one that I think's been alluded to already. The role of philanthropic dollars is so critical because it allows us to ask the very provocative questions, what people might call high risk, high reward questions that may not be asked otherwise. And so an example from our work, going back now over 10 years, we got very interested in my laboratory about a very simple question. And it's the question I hear every time I meet a patient who's newly diagnosed in the clinic, which is, how did I get myeloma? Why did this happen? How did this happen? And the truth is, nobody knows. We got really interested in that because we thought if we could understand how this happens, maybe we could prevent it, or maybe we could learn something that could lead to a curative treatment, or at least a very effective treatment. And so fast forward 10 years, the progress that we've made up to this point has been almost entirely due to philanthropic investments. Because when, frankly, we showed our data to funding agencies, we showed our data to peer review groups, and it was so far off the beaten path. It was so well beyond the straight and narrow that it was considered too risky to invest in. And now in December, actually, we were very blessed to receive a $10 million philanthropic investment to create a myeloma center here. And we have a portfolio of drugs, a compound library now of drugs to target this transcription factor that we discovered that we believe is critical to myelomogenesis, to the initiation, the inciting events that lead to myeloma. And the most exciting part of that is we've figured out how to turn that transcription factor off and make these cells die, or even de-differentiate into something that looks like a normal cell again. And entirely because of philanthropic investments along the way, from the Moore Foundation originally, from grateful patients that I've taken care of and their families, and now from the generosity of the Riney family to create our center. We're on the cusp of moving this into phase 1 trials. And I agree with Rob, the privilege of bearing witness to that, of seeing these really provocative questions perhaps being answered now is incredibly exciting and entirely due to myeloma. So in that center, we have 5 projects like that are all first in class, first in target, first idea, that arguably would be left undiscovered or unexplored if it weren't for philanthropic investment.
Thank you, Dr. Benson. I know I'll be really excited to hear updates about those projects in the future. Dr. LaPalambella, could you tell us a little bit about the novel therapies that you've been a part of or are currently working on?
Yeah, absolutely. And again, I want to also start by thank you all for your donation through the years. Like Dr. Bayoki, Dr. Benson stated, it really made a huge difference for all of us in our research. I truly believe that I wouldn't be here today talking to you if it wasn't for philanthropy. One, because I am a foreign student. I came from Italy 15 years ago, and I wasn't eligible for many government foundation or funding just because of not having like a green card at that time. So through philanthropy dollars that I was really able to get some funding and be able to do some research. So I had the pleasure to meet many patients through the years. I'm not a physician, but like taking to the tour of the lab, explaining my research. So maybe some of you is in the audience tonight. So I just want to thank you so much for all you've done. So I think one of the drug that I really excited about that I started to work on it was back in 2011. It's called selinexor, and at that time, this is a drug that targets a specific protein called XPO1. And what XPO1 does, like if you think about a cell, you have 2 components, a nucleus, which is basically the office where all, the most important action takes place and decide what needs to be expressed or not in a cell. And then there is a cytosol where things get produced. So a lot of the problems that we have with tumor cells is due to the fact that even if the proteins are there, to do their function, they're like mislocalized. And why they're mislocalized? Well, we discover many years ago that they're mislocalized because cancer cells become, very clever, and they overexpress this nuclear-like guardian. That what it does, it pushes, like those factors back into the cytosol, prevents them to enter the nuclear where they are supposed to have an anti-tumor function. So obviously, with this concept in mind, many companies are developing drugs that actually prevent XPO1 to have this function. By doing that, allowed those factors, those proteins, to go back in the nucleus and do their normal function, which is preventing tumor. So at that time, I worked with this company called Karyopharm, and we had, just like Rob described, we did some in vitro studies, some just to see if, especially in chronic lymphocytic leukemia, if this concept was true, can we block XPO1 and can we kill tumor cells? And that worked out great. So I remember actually going through different stages and of their molecules, and eventually picking with the company the one that made to the clinical trial. And then fast forwarding to today, that drug actually got approved twice by the FDA for the use in refractory multiple myeloma, as well as relapsed refractory diffuse large B-cell lymphoma. So Dr. Boyett and I actually have a study together to try to have combination of this drug with ibrutinib. And we are continuing to pursue other avenue of trying to make this drug even more effective. And considering that, just like PRMT5 that Dr. Bayoki mentioned, this XPO1 trick is actually present in every different type of cancer cell, not just in leukemia. So a better way to target XPO1, they're going to help not just the division of hematology, but they will be applicable in so many other type of cancers. So.
Thank you, Dr. Lambella. That's such a great story of how your preclinical work in the lab actually ultimately led to FDA approval of a drug. It's really impressive. And then Dr. DeLima, I know that you just came to Ohio State, but can you tell us a little bit about some of the novel therapies or interesting studies that your group has been working on that you're interested in translating here to Ohio State?
Sure. I think I have one mission, if you would, that it's not a specific project, but I think it's important as a continuation to a lot of the projects that are going around. And that is, there is a science to manufacturing cells that's commonly forgotten or ignored, because the vibrant basic science is what we are hearing here. And of course, we all envision some of these interventions reaching the patients. But there is one stage for those processes that involve large numbers of cells that need to be developed, in the sense that you have to create a process and an infrastructure that allows you to produce cells in numbers that can be used to treat humans. It's almost a step to finally bring some of the ideas that are in the laboratory towards the bedside. So this implies a significant investment for the institution to expand the cellular production facility that currently is very limited. It's small and, quite frankly, unable to actually respond to the demand in the institution. I mean, never mind the demands outside the institution. So I think this is one very important mission that the institution is very aware of, and I hope to be a part of this coordination, if you would. Now, when it comes specifically to projects, right? I mean, I think the group has had and will continue to have several projects clinically that are intended to minimize complications of transplant, especially from donor stem cell transplant, namely a disease called graft versus host disease. That's almost you could say that is the donor cells engraft, take in the recipient, but all of a sudden they ask, what am I doing here, right? I belong to that donor over there. and they try to reject the recipient. So this has been for decades a major barrier to successful transplants. So we have several lines of investigation, both in the laboratory and in the clinic, to try to minimize this complication. And the other broad strokes, as I mentioned, is cellular therapy, right? I mean, it's the possibility that we can get components of the immune system, say lymphocytes, part of our white cells, right? And manipulate them in a way that they become more able to recognize cancer structures, for example, so they can be trained. And this process of training them usually involves genetic manipulation in a variety of shapes and forms. And as I said, the trick sometimes now is to make it possible to reach humans, right? Because we have all the concepts, we have the techniques, we have the small scale experiments, and we lack the means to actually manufacture enough cells for some of these initiatives to reach the patients. So that's where we are now. I think this will be an exciting time. I mean, we're bringing a new vector, which is a virus that carries the ability to train the cells to target three targets, which is their number 19, 20, and 22, for example. And this would allow us to use the cells and prevent the cancer from escaping the current cells that are available. These are called CAR T cells. And commercially available ones target CD19, one of these three. So the idea is that if you target several, you prevent the cancer cells from bypassing and escaping that pressure from one target only. So I mean, I can go on forever, and I know we don't have time for that, but I think my major, if I may, buzz that I put in everybody's ear is that we are truly looking for a infrastructure, a core. We're looking forward to building a core here that would be a complement to everything we are hearing here. There's no, it really fits nicely in the general idea, and this will be a sizable investment. So I'll just leave at that, and thank you.
Thank you, Dr. De Lima. I know that was so exciting to hear about, and I think we're all really looking forward to starting new projects with you and moving some of your vision for cellular therapy in with each of our disease groups. Going back to Dr. LaPalambella, one of your roles in the division is to lead, and I know you do this along with Dr. Baiocchi, the division-sponsored research program. I was wondering if you could tell the audience a little bit about this.
Yeah, sure. I can start. So the division-sponsored research program started about 2.5 years ago. This was actually an idea that Dr. Benson had and at that time it was the interim director of our division. And the idea was to help our junior faculties to get some preliminary data that are necessary for submitting applications then to the National Institute of Health, our like the federal government, as well as other foundation. And so the idea was also to facilitate and encourage team building, so a collaboration among our faculty. So one thing that I want to stress is that, and that's why philanthropy is so important, is because it's really hard to get funding unless you have done almost like 80% of your research. Like it's because funding climate is really tough these days. Reviewers really want to see that you have the ability, and you've done most of your science before they believe you that you actually can do it. So because of that, really we rely a lot on philanthropy to be able to get those preliminary data that are necessary to submit those applications and to actually stand a chance to be successful. So with that idea in mind, we created this division-sponsored research program to I think we have team project as well as junior project. And again, the idea was to submit an application and get peer reviewed by our faculty, provide critiques. They're going to be fundamental for even when you go and apply for different funding mechanism. And at the same time, to provide support in terms of reagents, disposable, as well as effort for technicians or students and postdoc to be able to have the manpower to generate this data. So I think it's safe to say that it's been a very successful program. And then with Dr. Yang, when he became our division director, he really loved this program and took it to the next level by increasing the amount of funding that we have available, and putting this, giving us the possibility of running this program in 2 different cycles per year. And why I think it's been extremely successful is because we already start seeing the fruit of this program. We had several junior faculties that have applied for this and receive really that validation, the ability of doing those preliminary experiments. And then that really led to them be successful in receiving funding through the American Cancer Society, the Leukemia Lymphoma Society, the NIH, and then obviously from other like disease-specific foundation, like I know the Lymphoma Research Foundation as well.
Thank you, Dr. Lambella. That's such an important program that's really, like, as you said, helped a lot of faculty move on to the next step in their funding. And then Dr. Baiocchi, you talked to us a little bit about your research work. Can you tell us about your role in the physician scientist training program and the residency program and how the division interacts with those groups?
Sure. So one of my other roles is in the Department of Internal Medicine, where I serve as the Associate Program Director for the residency program and the director of the Physician Scientist Training Program. And a physician scientist is someone who uses their science as a tool to improve their patient outcomes and bring novel discovery forward. And one of the trends we've seen over these last several decades is a steady decline in the number of physicians that want to be a scientist and a doctor. And so about 10 years ago, Dr. Mike Griever, who was leading our department at the time, he actually allowed me to be the first person to train in this pathway about 20 years ago. After I trained, though, really there was no one else who came through the pathway, and Dr. Griever asked me to start a formal program to help bring residents through the pipeline to learn this the multiple skills that are required to balance your patient care with your science. And so we started small, and over the last 10 years, we've had 18 people come through the program or in the program currently. And it's been real exciting, because what this program does is it provides mentorship to young physician scientists. And that's the most critical ingredient for all of us. And without mentorship, most of us wouldn't be here where we're at. And I was fortunate to have great mentors like Dr. Michael Caligiuri, Dr. Michael Griever, and I basically applied the mentorship tools that I picked up from my mentors, developed mentorship teams for each trainee in the program, and longitudinally allowed these residents and fellows to find a laboratory home and develop unique projects to bring forward into faculty when they join faculty. And so far, we've recruited 5 faculty members from this program into our division. They're incredibly talented. Everyone in this program is just amazing. And it's just exciting to see people take their training as an MD or an MD PhD, but really bring it forward and bring new skill sets to the table, new ideas to the cancer field, and then apply it as a faculty member and really impact patients. It's a real exciting program, and it's something that's growing here, and it's also growing nationally. We've been fortunate to be involved with 10 other sites nationally to lead this program. It's nice to see the data moving in the other way, where we see a growing presence of physician scientists in training and in practice. So,
thank you, Dr. Bayoki. And thank you to all the panelists for your time and for sharing your stories today. I know you've provided our ambassadors a lot of important information that they can share within their networks. I'd like to now open the meeting up for questions from the audience, and please submit those through the Q&A button. And I think we don't have any questions just yet, so I have a few more questions to ask people. Dr. Benson, can you tell us a little bit about, in your mind, what sets the Division of Hematology here at Ohio State apart from other institutions?
Yeah, how much time do we have? I think the first thing is we're big. If we're not the biggest hematology division in the country, we're in the top 3 or so. It's very rare to have over 70 faculty in the hematology division. I think that sets us apart. I think somewhat paradoxically, the second thing that sets us apart, despite being so big, the culture of our division is fantastic. And so even though we all take care of people with different conditions, we study different diseases, we have our own focused interests, the sum is greater than the parts. And I know that sounds cliche, but we're a very diverse division. Over half of our division are women. And I think evident in Yiping's slide, over half of our division leadership are women. And I personally have a tremendous sense of gratitude, not only because of what we do, it's because of who we are. And I think the reason that's important, and it extends into our nurses and our nurse practitioners and the whole group, but the reason that's important is it creates opportunities for us to support each other in our work. For example, in myeloma, we have a clinical trial of ibrutinib going on right now, the drug that Jennifer developed. And we've been talking with Rob Bayoki about PRMT5 in myeloma, and that kind of environment ultimately is good for patients, and it's good for our mission.
Thank you, Dr. Benson. We do have a few questions now. Just a reminder, if you have a specific panelist that you want to answer your question, if you could put that in, that will help me direct it toward the right person. But here, this one's pretty obvious. For Dr. De Lima, what attracted you to Ohio State?
So I think it's a relatively easy answer, right? I mean, you've heard the breadth and the of topics and different mindsets and ideas in 30 minutes, right? Here you see how these projects that have been incredibly successful. So easy sell. I think also I want to echo what Dr. Benson just mentioned about the culture, which I am a witness now, and I was told about it, and I knew a little bit about it, and I believed it, and it's real. And one can only expect that this type of culture that's open and collaborative will basically be this place to grow ideas, right, and projects and such. So very easy sell. I should have come earlier, actually. Took me a while, but here I am.
Thank you, Dr. De Lima. The next question, it says, it's been a challenging year with the pandemic. What has motivated you? If you don't mind, I would love to answer this question a little bit, and then maybe I'll ask one of my colleagues as well. But I think, from the very start of the pandemic, we all saw that our patients with blood cancer were particularly at risk to get very sick. And so I think, among the whole division, people were really invested and interested in doing everything that we could to help our patients. Some people did this by repurposing their lab to start studying immune responses to COVID. A number of people in our division did do and continue to do a lot of research looking at how the immune cells in patients with hematologic malignancies are affected by COVID and how you could potentially make those responses better. Some of us also, members of our lab, started worked with the efforts to do testing when testing supplies were in short supply. People donated from their labs to do that. One of the things that our group did is we hypothesized that one of the drugs that we use for CLL, ibrutinib, it inhibits a protein called BTK, and besides being really good at killing CLL cells, if you inhibit BTK, you shut down a lot of inflammation. And one thing that had been shown previously by another lab is that inflammation is actually really important in immune responses in the lungs to viral infections. So we actually worked with a company that made ibrutinib, Janssen Pharmaceuticals and Pharmacyclics, and started a clinical trial where we've been treating patients who have any type of cancer, who get COVID-19, get hospitalized with this drug to see whether we can improve their outcomes. I'll have to tell you probably in a few months whether it works or not, but I think it has been working very well, and it's been very exciting, and for our group at least, really gratifying to be able to take some of our knowledge in hematology and use this to help patients with COVID. So next question, this is from Gretchen McNally, one of our nurse practitioners. There are many exciting discoveries of new cancer treatments. Can you discuss survivorship issues and research? And I might direct that one to Dr. Baiocchi, if you don't mind.
Well, I think, one of the areas that I could speak to is one that's actually near and dear to our own clinic, is the problem of opiate addiction. And the huge dent it makes in survivorship and quality of life of patients after they've come through a cancer diagnosis and a therapy. And we've really seen this explode as a problem nationally. And I'm real excited about a few of the initiatives that have started with a focus on this and raising awareness of our healthcare providers who really aren't always all that aware of our prescribing habits and the impact that this has directly on our patients and patients across the nation. And I think that there's a couple of exciting programs going on here. One actually led by Gretchen McNally, who's in my clinic, and we work together to take care of patients with lymphoma, but I've been real impressed with her innovative ideas to bring programs forward to raise awareness of opiate addiction and how to tackle this from an institutional standpoint. I think that's just one example of how at a cancer center, we're not just thinking about the disease, but the patient as a whole, and how to really improve patient quality of life from all angles.
Thank you, Dr. Baiocchi. Next question is for Dr. Benson. What is the biggest development in treating myeloma in recent years?
Yeah, I think I want to just add briefly to the COVID question, the dealing with the pandemic, and I think just emblematic of the culture and the group that we have. When COVID exploded just over a year ago, the institution as a whole really did this tremendous job of triaging and creating teams to take care of people with COVID in the hospital, and multiple groups stepped up and volunteered, and it's really an amazing effort by everyone, the critical care docs, the ED docs, everybody. But what I've never been more proud of our hematology division than I was the day that we discussed this in a faculty meeting, and unanimously the group said we want to take care of our own patients. just because they get COVID doesn't mean I don't want to take care of them. And so as a division, up until today, actually, we've always taken care of our own, and particularly proud of that. In addition to clinical trials and the research that's going on to improving outcomes. So I think that the biggest advance, the biggest development in myeloma is the recognition and the understanding and the appreciation that myeloma is not one disease. That the cells all look the same under the microscope, but they're being run by different programs, by different mutations. And I think we are getting to a point in the field where we're beginning to personalize therapy. So for example, we have a clinical trial open for people with myeloma where the patient comes into the trial and we sequence their myeloma genome and we identify what mutations are responsible, what mutations are driving this relapse. And then they are treated in an algorithm with what are called targeted therapies. So drugs that are specifically designed to attack and disarm that mutation, to prevent that mutation's function. And so not all myelomas are the same, but even in an individual patient, they may have subclones of myeloma cells with different mutations. And so we're getting to the point where we can rationally combine these targeted therapies and even prospectively identify who may benefit from a CAR T cell, who may benefit from a bone marrow transplant, who can just take a pill once a day and go live their life. And for me, that's incredibly gratifying to not go off a cookbook, not go off, this is how we've always done it, but really be intelligent in the care that we can deliver.
Thanks, Dr. Benson. We're just about to the end of our time, but we have one question left. So I'll give Dr. Baiocchi a chance to answer this one. If the PRMT5 inhibitor does well in clinical trials, will it be used as a frontline treatment or only after chemotherapy has failed?
I would love to see it one day as a frontline therapy. Believe me, this is there's nothing more exciting than to see a drug move forward and make an impact. Unfortunately, this is a long road. The phase 1 trials will be finished this year. We'll have a phase 2 that we'll go into in select diseases, depending upon what we observe in the phase 1. And if there are significant responses in different target diseases, diseases like glioma, which really don't have a good upfront standard of care and really haven't seen a new drug in decades, this would be a good option. And it would be a major advance forward for patients with that disease. For other diseases like lymphoma, where patients can receive therapy and have good outcomes, it probably, if it did apply to that disease, would be something that would come in after disease resistance develops. But at this stage, being so early in the development, the clinical development of this drug, we really need these clinical trials to teach us the best way to move forward with the development and target specific patients that will benefit most. So honestly, I'd love to see it make an impact like that. That's why we're in this game. But yeah, that's where we're at. So thank you for the question.
Thank you. I have one last question for Dr. Yang. I think this is an important one, so we'll end with this one. Dr. Yang, how is the division expanding to the West Campus, new buildings that are going up? Can you tell us a little bit about that?
Yes, the expansion into West Campus, that's a tremendous opportunity for us, but the growth of hematology program, the care of patients, the building now has been almost very close to the completion, and we expect to move in sometime next year, I believe. So gonna expand our capacity of patient care, chemotherapy area, and research on the West Campus. Very exciting development. And around the West Campus clinic building, there's also a adjacent research building next to it within a couple of minutes next to each other. Research building, and also the part of that is the Palatonian Immune Oncology Institute, immunotherapy research building next to that. And yes, very exciting. And then on the longer term, there's also going to be a inpatient facility planned for on the West Campus in few years to come.
Thank you, Dr. Yang. I'd like to thank our audience for spending your evening with us. Thank you to my colleagues for providing us with new and exciting information to share within our networks. If there were any questions that people put in that we didn't get to, our team will follow up with you post the event. We hope that everything you've learned this evening has given you a better understanding of how the Division of Hematology operates and what sets our cancer program, our research, and our hospital apart from the rest. Thank you for continuing to stay informed. Take care and have a great evening.